Good afternoon, everybody. My name is John Whitman, and I'm a faculty member at the MBA Healthcare Management Program at the Wharton School in Philadelphia. And today I have the pleasure of monitoring a very timely webinar. It's titled The Blueprint for Preventing Future Pandemics and Decreasing Infections and Hospitalizations. And joining me today, I have two representatives from a nursing home chain based in Hampton, Ohio, called ABCM. It's a privately held company. They have 31 skilled nursing facilities, 24 independent living facilities, and a durable medical equipment company. Dr. Sam Stanton, who's the medical director, will join us, as well as Lindsay Henry, who's on the front line and one of the DONs in their facility in Hampton, Ohio. Dr. Stanton and Lindsay will be talking to us about the successful efforts they've made to prevent the spread of COVID, to take care of their people with COVID, but more importantly, to continue a high level of quality care to the residents of their facilities. Also joining us is Dr. David Chess, the founder and the medical director of a company called Tapestry Health out of Connecticut. Tapestry is a multi-specialty primary care physician practice that takes advantage of telemedicine and remote patient monitoring to assure the highest quality of care for companies like ABCM and other nursing homes around the country. Dr. Chess, I'd like to welcome you, not only for this program, but also Dr. Chess is one of the true pioneers in telemedicine, been doing this longer than anybody else I know. And last I heard, he's up to about 15,000 individual nursing home visits using telemedicine. That's pretty impressive. So welcome, Dr. Chess.
Thank you very much, John. Thank you for hosting this seminar. And I appreciate all those who have joined us in this effort. So, COVID in many ways has really forced us to redefine who we are as facilities and how we care for people. And it's really crystallized the need for a full integrated model. So much of what we do in healthcare is siloed. We have the medical director here. We may have a nurse practitioner on site. We have all these pieces. But in order to effectively manage and control COVID in the nursing facility setting, you really need to have an integrated approach. And with that integrated approach, it really is everyone. That big coronavirus affects everyone in our lives nowadays, from the patient to our frontline staff to the families. And so it truly takes a village to control the infection, and infection control has now become a way of life in nursing facilities. And if it's not that in your facility, then you're in trouble. So creating this integrated model requires everyone. There needs to be internal nursing facility protocols and processes. There has to be extensive education and training. Every single person who enters a facility has to be part of it. So that includes the dietary, your housekeeping, your social workers, your activity directors. Every single person is a potential vector for the infection entering the facility and hurting our frail elderly. So engaging everyone is fundamental in education. And education, as you all probably know, has a half-life of about 30 minutes. Excuse me. It's not my COVID. I tested negative.
I don't know. Started. They have 32 facilities, and they have
what is this?
No COVID.
Someone needs to be on mute.
No COVID.
Who is?
Yes.
That organization.
Really?
Could you guys mute yourselves, please, whoever's talking?
Listen, the positivity rate in Palm Beach County is 6.7.
I can't see who that's coming from.
So we're on weekly testing anyway.
Yeah, no, I just hope it doesn't go up to twice.
If someone can mute, I appreciate it.
And so is Dave, but Palm Beach is the highest.
It's Go Osborne.
So
News yet?
Oh.
Can you go back up in the slides?
Yes.
Okay, so includes everyone in the facility, and education is only as good as the prior slide, please. Education is only as good as your re-education plan. So it's not doing it once and you're done. Most education nursing facilities, the nurses are worried about 100 other things while they're getting educated. So you really got to get everyone's attention. And you have to have random shift monitoring. You can't just teach and then not go back and monitor. I can't tell you how many times I've seen nurses wearing their mask underneath their nose. I can't tell you, I had a patient the other day I was seeing who was hard of hearing. The nurse took off her mask to yell at the patient so she could hear. And so that's a blast of potential viral particles. So we really need to reinforce and have playbacks and train. Communicating with patients and families are critical. Next slide, please. And it's so often that the first symptom, the first thing you're going to know is the nurse will say, "My patient isn't herself today." It's often very, very non-specific. They just don't feel themselves. And one of the earliest things you'll find, and I really recommend this, is to monitor the amount of food eaten daily. So if you see someone who's usually a good eater and now they're eating 50% or less, that's a red flag. So I know we all know about the loss of smell, but there's a real diminution in appetite. So we've been trying to set up a monitoring system for dietary intake, for fluid intake. I know most facilities are doing the temps and the O2 sats daily or twice a day, I hope. I really suggest as much as possible to add to that blood pressure and pulse. There needs to be a real monitoring of mental status changes. Because that is, if someone doesn't want to get out of bed today and they're usually getting out of bed, that's a red flag. They need to be seen. And then you need to have your viral screening of your asymptomatic staff, on a regular basis, as well as your patients. I know every state has a different mandate, and I know it's very confusing, but the more you can do, the better and safer your patients will be. Patient sequestration at the first signs of an issue is really critical. So I know that it's very hard on patients, but you can't wait until your results are back. You've got to sequester the moment you think the person may have COVID. And then, you get a negative, release them, that's great. There is a real issue in terms of the state regs, which vary from state to state. And the guidance from CDC has been perhaps not as strong as we would like it. And it often lags behind the science. And so what we've been trying to do as much as possible is use testing to get our patients released from being sequestered in the rooms. I can't tell you, I've had a number of patients who sequestered, they're confused, they fall, they break their hip. It's been just horrible on individuals, both physically and mentally. So, and it costs the facilities a ton of money in PPE. So that's something that the more we can use testing to get them out of the room, the better. Next slide. Next slide, please. So medical care is a 24/7 job. Your medical staff must be available to you 24/7, and they need to round on all your patients with COVID, whether or not you think they're bad today or not. They look fine today. There's massive swings in judgment between the nurses. This is a disease that changes overnight. Not only overnight, it changes from one shift to the next. So getting it right is really important. And getting people seen early, sequestered early. And again, looking for the different signs: behavior changes, appetite changes, cough, shortness of breath, vitals, nausea, vomiting, fatigue. And you have to have people available 24/7 to both take a phone call, but also to go see the patient. It makes an incredible difference. And so we at Tapestry leverage the telemedicine to be at the bedside within moments. And as a medical group, we provide on-site care, we provide telemedicine. It doesn't matter to us which way, but we want to have someone seeing the patient. Next slide. And so this takes a truly integrated model. This is really, if you think about COVID, how it's changed our world, well, I think it's helped to mature what the medical model within a nursing facility needs to be. Nursing facilities over the last 10 years have gone from nursing facilities to taking care of really sick people that need a lot of medical attention. And this has really just accelerated that evolution. And so you need an involved medical director, you need committed attendings, you need to have 24/7 availability to see people. Integrated behavioral health is important. And now we're layering in a bunch of biometric monitoring in our facilities. And then nothing works if you don't talk to each other. So communication, so being on the same platform, being able to communicate in as seamless a way as possible. As I'm medical director in a bunch of facilities, and we have weekly meetings, we have strategy meetings to update because again, the rules are changing in the states. The load of COVID in that community is changing. So we update our strategies, we address issues, and we make sure everyone's on the same page.
Thank you, Dr. Chess. What I'd like to do is ask Lindsay to talk to us for a couple of minutes. Lindsay is a DON in one of the facilities of ABCM right in Hampton, Iowa, and been very actively involved on the front line in implementing a program that ABCM has put into place to help address COVID. But Lindsay, I'd like you first to talk a little bit about pre-COVID and how things were operating and how they've changed now that we've gone into a COVID mode, if you would. So welcome, Lindsay.
Thank you. So yes, pre-COVID, we have Dr. Stanton is not only our corporate medical director, he's actually the facility here where I am at, Hampton's medical director as well. So we've been very fortunate to be working with Dr. Stanton for a long time. And so we were also very fortunate to be one of the first ABCM homes to implement Tapestry. So Tapestry, when it was first implemented for us, was to help decrease rehospitalizations, help decrease ER visits, help decrease those situations where once a resident gets comfortable in our home and is sent to the ER, you know, it can be very confusing, can be very just hard for that person to handle. So we started working with Tapestry pre-COVID, so we were able to develop that relationship. So then COVID hits. COVID was very scary. The symptoms of COVID can be symptoms that these elderly people experience on a day-to-day basis, depending on what their diagnoses are. So when they came out with the list of symptoms we're supposed to be screening for, the nurses would identify one of those. They would put the person in isolation. We would contact Tapestry. Tapestry physician would then see the resident, listen to their heart, listen to their lungs, all within minutes. And so that was imperative. And then deciding the further plan of care, they could order the COVID testing. We had at that time, very early in COVID, we didn't have the rapid testing like we have now. So now it's even better. We can do the rapid test. Pending those results, we can send off for the PCR as well. But all those orders are obtained within minutes. And the person is also seen. So I am very grateful to our medical directors, Dr. Stanton and Dr. Chess, for bringing this to us. It's been nothing but good.
Thanks, Lindsay. Dr. Stanton, I'd like to turn to you now. You've developed a response to COVID for the ABCM facilities that's been very effective, was implemented in a relatively short period of time. I'd like you to describe that to our audience, if you would, and welcome to the program.
Thanks, John. ABCM strategy, basically, ABCM is a large organization of 31 nursing facilities. And our strategy, basically, even though it's a large organization, it still functions very much like a mom and pop because it has a single owner in Mr. Albee, Dick Albee, who's the surviving owner. He's the A in ABCM. And so I just called him when we saw that this was starting to hit the state, and actually a little bit before it got into Iowa, and said, hey, this is what I think. And we had a really good dialogue and said, okay, let's do it. And so what we did was, first, we really worked at understanding what the threat was based on what we could ascertain from really Washington State was a big source of information for us, because that's where, as everybody probably knows, the initial bad outbreaks in nursing homes hit. And so as I studied up and read and understood, the basic strategy was that if you can keep community transmission down, then it's less likely to get into the facilities because your staff are living in the community, presumably. And many of our staff live in that county around the nursing home that come in. And so we really kind of took this idea that, well, if we can't control what's going to go in the community, then at least we could put in a robust screening program that's going to not only detect the symptomatic folks, but also the asymptomatic folks. And so we had some kind of technical understanding of what to do and what we wanted our folks to do. But really the power behind our response comes, as usual, from folks like Lindsay, who was just speaking. It comes from them transitioning from knowing how to do something to doing it. That's where that tacit, it's education, but it's really the training, actually applying what you know so that you develop an understanding. And so our strategy was based on this idea that the more intermingling that you're going to see among young people, daycares, students, folks out in the communities, the higher the community transmission is going to increase, the more likely we're going to have asymptomatically or pre-symptomatic infected staff coming in. And so we needed to be screening these folks, not just with the tools and the checklists that we got from CMS and ACA and AMDA, but actually we needed to be testing them with PCR to screen for the asymptomatic or pre-symptomatic folks that we couldn't see using those checklists, that we needed to have some idea of how to screen those out. You would go to the next slide, John. And so this came from my discussion with Mr. Albee. The strategic level response was we needed a top-down restructure, which we literally did overnight. We had company consultants that could no longer go into the facilities, and we thought they'd be better off actually working as liaisons to the facilities and having a telepresence interaction with them day to day. With the idea being that once we increase the tempo of change around the facility, from regulatory change, testing, telehealth things, the transmission rates, the requests from families, the PR need, all of these things create an increased tempo that's necessary for the administrator and the DONs to make decisions and use their initiative to come up with new systems, new processes, be innovative. So we made a very deliberate commitment to pushing all the decision-making down to the front lines as low as we could get it, which frankly has been done for hundreds of years in the US military. I'm a veteran, and this is where I learned how to do this. And then our job at corporate became supporting the development and the delegation to these folks through our COVID liaisons, who are now working and making connections with day to day. So there was a reciprocal exchange up and down as a network. And we looked at each one of the facilities as really a team that were setting the conditions for them to be able to innovate their way forward to whatever the conditions are in their immediate community. And then what we did was, once we got some of that structure in, which really took about a week for everybody to understand what the structure was and how we were going to interact with one another, we set the objectives of detect, isolate, diagnose, and contain. And these flow from left to right. And what we said was, in an ideal situation, we are detecting, isolating, diagnosing, containing everybody who's got COVID instantaneously. There is no delays in our ability to move from detect to contain throughout that process. And then underneath each of those objectives, we look to the facilities like Lindsay Henry and her team in the nursing home to tell us at corporate what they wanted to do. What were the gaps for them being able to achieve that? Was there a delay in getting a doctor's order? Is there a delay in being able to isolate somebody because they don't have the PPE they need, or they don't know what the rules are coming out from the direction of the Iowa department? Do they have the ability to detect asymptomatic individuals in addition to symptomatic? We developed the tools and the policies, and if there was a gap in understanding, which is really the fundamental gap, then we ended up having more discussion and coaching on that through our COVID liaisons. But we listened to them. The COVID liaisons work not just to push to the nursing homes, but to pull from the nursing homes and bring to us, what do folks like Lindsay need? And then at the end is just sustaining, staying in alignment, understanding where are the gaps, because the environment changes all the time, continuously. A facility can get out of alignment from meeting their objective, and they have to stay very watching that workflow. Lindsay's out there watching. What are the staff doing every day? Oh, they're not donning and doffing PPE. We need to close that gap. Or we're running low on our supplies of gloves. We need to close that gap. We can't do that by ourselves. So let's get the COVID liaison, send a message to corporate to get their help in acquiring gloves. You know, all these gaps that occur just in the course of daily care around individual patients. And so every day at corporate level, we're talking about individual patient care across 31 facilities, which has greatly sped up our ability to make sense of gaps in individual resident care and do something to try and fix that. That's empowering to the front line. So basically, we just said, under each one of these objectives every day, we ask ourselves, what are we doing to achieve that objective, and how do we know that we're closing the gap? How do we know that this is the gap, and how do we know that we're closing the gap? It's a root cause exercise, which is basically just a PIP, if you think about QAPI PIPs. Next slide, John. So the next two slides, this one and the next one, are actual slides from our daily presentations. So as an example, one day at corporate, we were working on door screening, monitoring, and asymptomatic testing. And we were asking, what are we doing to actually be able to detect people coming in for visitation? Is our door screening tool not just adequate from our eyes, but is it understood by the frontline staff? Is the monitoring tool that we're using to screen residents every 12 hours not just make sense to us at corporate, but is staff actually using this? Are we closing that knowing doing gap? And we rely very heavily on folks like Lindsay Henry to be able to tell us that. We had phase scorecard at some point for reopening so that our corporate level folks could talk to families and take some of the burden off the facilities. Our data reporting is always a moving target. And then next slide, please. Under the diagnosed categories, what we ran into at one point very quickly was, what's our provider engagement? There's a lot of variation in one provider to the next, even within the same community, on when they wanted people sent to the ER, whether or not they're going to follow NIH guidelines or even are aware of the guidelines, when they're going to test, how they're going to test. So we really aggressively got telehealth out there. We had it in some facilities, as Lindsay said, before COVID, but we very aggressively put it out there afterwards. And so that was a big point for us to be working on at some point as well. We had some other DIA survey issues that come in, you know, just continuously looking for what are the facilities running into at the front line. And then this just kind of puts in a visual construct how that looks. If the SNF team, we consider our 31 facilities a fleet, and each one of those facilities is a ship sailing towards our objectives. If they're getting off course and heading towards a storm, meaning they have delayed testing, they're waiting 5 days to get PCR results. Why is that happening? We need a root cause of why that's not occurring swiftly and get them back in alignment with those objectives. And then here's a summary of our testing through the 25th of October. We've done almost 30,000 at that point, 30,000 PCR tests, which is almost 3.5% of the entire state of Iowa. Is a phenomenal amount of just our organization, just our 31 nursing homes did almost 3.5% of all PCR testing for the state of Iowa. Our 7-day positive rate as of the 25th, we had 1%, about 1.03% of our residents positive and 0.69% of our staff. That's in contrast with on the 25th, the percent positivity rate for the general public in Iowa was 13.1%. So when we make the argument that you're safer being a resident or an employee of ABCM than being walking around in the general public, and we owe that to folks like Lindsay Henry and the frontline leaders, we are supporting them to take the initiative and figure out where these small gaps are and close them. Cumulative numbers are down there. We have had outbreaks, just to be, you know, totally transparent. We've had several outbreaks, but what we've found is that where we have systems and processes where frontline staff, and especially DONs and administrators, have been very aggressive at looking for gaps among the staff, the outbreaks have been 5 to 10 people versus 30 to 40 people that we've seen in places where the leadership and the team wasn't there. So what this shows us here is actually a timeline for our facilities. The next few slides show that we had surge at the end of June at our Mason City facility in Saragoro County. And so the line up and down is showing the county transmission rate. So you can see there in the middle of the end of June, you had a surge to 20%. And that actually was when we started screening out staff. The orange bars represent the number of staff that are screened out during that time frame. And we had screened out 5 staff that week. They had a surge. Next slide. The same county, we have another facility in that same county that screened out again, another 5 staff. there was an outbreak at a non-ABCM facility that was something in the range of 146 people during that surge. And so that was thought to be a big part of that. Next slide. This was another one, basically same thing. You see the community transmission rate goes up. We screened out positive staff. Again, these are all asymptomatic staff, by the way. Some of them are pre-symptomatic, so they go home and they get sick after they're at home. But actually during the screening process, they're coming into work and we're catching them before they become symptomatic. Or, you know, in the majority of cases, these are asymptomatic folks that never have symptoms. And then this last one was particularly compelling to me, that our Winnebago Lake Mills facility, we had 7 staff that screened out. Only 2 residents ended up getting positive, but they were just taken out left and right. The staff would come in 2, 3 at a time, would get sick, which put a lot of strain on the facility to find staff. We had to go to agency, pool help, things like that. But it really paled in comparison to the amount of cost that went in when you had a full 30, 40 people outbreak or more. It was, and they did a very good job. But once they started experiencing some of those positives, the staff and the leadership really got very, very, they closed that gap between knowing and doing, and they started finding a lot of the gaps in the system.
Dr. Stan, it sounds like the process was quite effective, and the teamwork effort is, I'm sure, part of that. What or how important is the role of telemedicine in this overall game plan for you?
It's a great point. So if you think about the people working in the facility as a team, what telehealth does is it places an extra element onto the team that doesn't exist there otherwise. You cannot, for a provider and myself, I use telehealth for my practice. There's no way for me to make sense of what's going on through a fax or a text. I have to completely depend upon the assessment of the person who's there, which in some cases, like Lindsay Henry, that might be pretty good. But in most cases, it's not, because I don't have that relationship. So what telehealth does, and I would say some telehealth, it really depends on the providers the telehealth company hires. Because what you're looking for is the technology to enable the relationship, right? So we all know that you can have somebody in the same room that you're not going to work on a team with because you don't get along and you don't listen to each other well or whatever. So what really matters, what I encourage people to think about with telehealth, and we've used a lot of different telehealth vendors, but look at the relationships your frontline staff are developing with the telehealth provider, because just having the ability to do telehealth does not necessarily translate to the outcomes. You want to have the ability to use the technology to create the relationships that allow the shared understanding of a situation to happen.
Excellent response. I've done multiple studies in telemedicine, particularly in nursing homes, and the equipment is the equipment. It enables the communication back and forth. The quality at the end of the day, or what really makes is the quality, the clinical quality of the physician, but also their communication capabilities. They're both very, very important. And with that, I'm going to bring Dr. Chess back on. Thank you, Dr. Stanton, and ask him to just quickly review the Tapestry Health approach and what they're using at ABCM.
Yeah, so to Dr. Stanton and John's point, for me, it's never been about the technology. It's always been about the person behind the screen. And so developing a team of great clinicians, people who really care about what they do, and where it's not just, you're not just clicking, but you're caring, is everything. And so what we try to do is to bring 2 facilities, and we're currently in close to 30 states right now, and bringing systems of care. So trying to fill in the gaps. Every facility is different. Everyone looks different. We try to fill in the gaps in terms of what they need. Do you have a full-time presence of an NP on site every day, or telemedicine wise? Do you have after hours? How's your behavioral health? What consulting services are most important to you? We've now really begin to embed biometric monitoring directly into the vitals that we collect with patients, and we provide, and we have a whole bunch of facilities. We got into this because we kept being asked for it, is medical director services. So we're actually providing medical directors to facilities now in, I think about 24 nursing facilities. So, and it creates an integrated model. So everyone's on the same page, using the same information system, et cetera. So, so COVID is really a model, not just for this pandemic, but it's created the ability for us to model for infections in general. And I believe we're going to be taking what we learned from this and applying it in general. And you're going to see lower infection rate, lower issues around antibiotic stewardship. And then we're much more ready for new surges and new challenges. So I'm grateful to have had this chance to share this all with you.
Thank you, Dr. Jess. In the interest of time, because we're at the end of our 30 minutes, and I hope it was helpful to everybody. Any questions you might have, rather than take your time now, we will respond to by email. On this slide, you'll see the email address you can reach out to for copies of the slides or to ask any specific questions, and a phone number. And with that, my name is John Whitman. And again, thanks for joining us today. We have another webinar coming on December the 2nd, and are continuing efforts to build a reliable, durable medical infrastructure for nursing homes. So we hope you'll join us. Be on the lookout for more information about that particular webinar. And again, any questions you might have, feel free to reach out, and we will respond. Thank you so much. Have a great day, everybody.
Bye-bye.